PAS is really challenging to diagnose. And I think that increasing awareness and increasing education to OBGYNs and to radiologists outside of the Madison area about what PAS looks like and what risk factors are and when patients should be referred would allow for patients to be referred in an earlier gestational age and, ideally minimize transfers from OR to OR when they're recognized intra-op at another facility, which is obviously not the ideal case.
Hello and welcome to our Winnovations podcast. I'm your guest host, Dr. Frank Lin, and we have a great program planned today. In this episode, we'll be diving into a critical topic in one of the subspecialties of obstetrics and gynecology, maternal fetal medicine. This program is entitled Complex Obstetrics and Placenta Accreta Spectrum. One of our many collaborations within the Department of Urology is the Department of Obstetrics and Gynecology, and we're fortunate to have two of my collaborators here, Dr. Erin Bailey and Dr. Michael Beninati. Dr. Bailey is an assistant professor of obstetrics and gynecology at the University of Wisconsin. She is a practicing academic maternal fetal medicine specialist. She completed a 3-year maternal fetal medicine fellowship at Wisconsin, and prior to arriving at Wisconsin, she completed her obstetrics and gynecology residency at Washington University in St. Louis. Thanks for being here.
Hey, Frank. Thanks so much for having me. It's a pleasure to be here.
Our second guest is Dr. Michael Beninati. Dr. Beninati is an assistant professor of obstetrics and gynecology, also at the University of Wisconsin. He is a native Floridian and actually joined our faculty in 2021. Dr. Beninati did his residency at Baylor College of Medicine and fellowship in maternal fetal medicine at Brown University. He also went on to complete a second fellowship in surgical critical care here at the University of Wisconsin. Great to have the both of you on the program today.
Thanks for having us.
Many of our listeners are familiar with obstetrics and gynecology, also known as OBGYN, but the field of maternal fetal medicine is highly specialized. Erin, can you tell us what diagnoses MFM specialists typically see?
Sure, Frank. We see a wide range. So as the name implies, we cover both maternal and fetal high-risk indications. So on the fetal side, we do the diagnosis. We run the diagnosis center and ultrasound and care for all of the fetal concerns that arise throughout pregnancy. And then on the maternal side, which is, where we're more focused today, we care for both medical and surgical complications of pregnancy. And that can range from anything from, patients who have high blood pressure and diabetes to rare rheumatologic conditions, patients that, have cancer or other rare complications. And then we also help manage a lot of the very complex surgical patients who also happen to be pregnant.
Erin, that's a great overview. Mike, tell us briefly just about the subspecialty within MFM of fetal surgery that you also are managing.
Fetal surgery at UW is housed under the UW Health Fetal Treatment and Diagnosis Center, and we focus our efforts on diagnosing pregnancies that are affected by structural or placental abnormalities and counseling those patients, as to the breadth of their options available to their fetuses, and then performing intervention during some of those pregnancies when we think that our intervention could help with life-limiting or life-threatening fetal conditions.
Really nice overview of just how in-depth the maternal fetal medicine subspecialty gets. Our focus today is specifically placenta accreta spectrum, also known as PAS, and the recently established PAS Center here at the University of Wisconsin. Let's start with Erin and describing what PAS is. What is it exactly? And tell us everything you know about it.
Yeah, that's a great question. So placenta accreta spectrum is essentially abnormal adherence of the placenta. It usually arises when there's been disruption to the inner layer of the uterus, so through the endometrium into the myometrium. The most common cause or risk factor is a prior C-section or surgery on the uterus, although it could be Also, really any manipulation of the inside of the uterus. So dilation and curettage, IVF pregnancies in and of themselves increase the risk. And the thought is that it causes disruption to that lining and scarring. And so then when the placenta implants, it essentially implants too deeply. And the way that the blood vessels form cause increased vascularity to that area of the placenta. And the reason that we care so much about it is that following delivery, when the placenta usually shears off and is able to be delivered spontaneously, it doesn't in these cases and can cause life threatening bleeding, often requiring a hysterectomy.
Mike, how often does this actually happen that we're seeing it clinically?
Well, UW is a referral center for placenta accreta patients. And so, I think in large part due to the collaborative work of this team, we're getting referrals for evaluation for this sort of condition, uh, several times a month and, operating as a team, dozens of times per year.
Do you have a sense of the percentage of total pregnancies that end up having some sort of placenta accreta spectrum diagnosis?
I don't want to say the wrong percentage. Aaron might know it better than me.
It ranges quite a bit, but the estimates are about 1 in 250 to 1 in 500.
So not common at all.
Pretty rare, but it is increasing as we're seeing increasing rates of in vitro fertilization, and increased rates of C-sections. Certainly, the rates of placenta accreta spectrum are increasing nationally.
So what I'm hearing from you guys is number one risk factor is prior cesarean section and in vitro fertilization, both of which are increasing, and therefore this diagnosis is seen more frequently now.
Absolutely.
Tell us a little bit about the impacts on mom and the baby.
So, thankfully, this is a diagnosis that doesn't tend to impact fetuses significantly. Um, Fetuses are still able to get everything that they need, and the placentas still function well. So we don't see increased risks of growth restriction or anything along those lines, which is often reassuring to patients when we're talking about it. The real primary risk is to the patient themselves. Because of the risk of hemorrhage and bleeding, we see increased risks of needing blood transfusions, increased risks of ICU admissions. I think that a lot of patients have a pretty good understanding of the significant surgical risks associated with placenta accreta spectrum, both from doing their own research and then from, meeting and consulting with us. And so I think that the mental health impact and the stress associated with the diagnosis really can't be underestimated either. I think that there's a lot of evidence, and I hear from a lot of patients about how stressful that can be. And then, we also tend to deliver these patients early because we know that when we do these surgical cases in a planned manner, the risks are lower, meaning that blood loss is lower, the risk of damage to surrounding organs is lower, the risk of needing blood transfusions is lower. And so the goal is to really perform these surgeries prior to labor starting. And so we generally aim to perform the surgeries between 34 to 36 weeks, which means we're then also delivering a baby preterm. And then a lot of times these neonates then end up needing to go to the NICU, which can be stressful for families as well.
That's a great description of the pathway that patients really have to endure. You mentioned a really specific piece of that, which is the amount of anxiety and stress that a patient can have as it relates to placenta accreta spectrum. Can you speak a little bit more about that and some of the research that's been done previously and currently?
Yeah, absolutely. I think really in the last few years, this has come to the forefront, not just within the world of placenta accreta spectrum, but also just in obstetrics, and recognizing that obstetric trauma is a significant contributor to stress and to PTSD afterwards. And so there's been a lot of really interesting work that's come out that's shown that that happens, which I don't know that people recognized so much before. And so, I think acknowledging that and recognizing it is a good starting point. And then also, a lot of data about really providing support and following up with patients in the postpartum period, and recognizing the need for mental health services during that time. Obviously, the postpartum period is a high risk time for anxiety and depression at baseline, and so then we know that when you add a very complicated traumatic delivery of any kind, but certainly of a placenta accreta spectrum type, it certainly increases that risk for patients really significantly. And so there's been a lot of work in going into how to minimize that and what resources are most helpful for those patients, and providing mental health support to these people afterwards and in the postpartum period.
Yeah, it's a huge consideration. As surgeons, we are so keen on managing the surgical intervention itself, but not understanding the patient so much as a whole. And this is really a great sort of different angle and different lens to look through. Let's talk about the PAS Center at UW. Mike, you started in 2021, around the same time I did here at UW. Tell us what the PAS management looked like back in 2021 and the sort of management and how that's changed.
Prior to our work together, Frank, there wasn't necessarily as much organization regarding PAS care at UW. The majority of those cases did not involve MFM or urology in the OR or in the surgical planning, really, because the majority of the cases were handled by members of the GYN oncology team, and those faculty members did a great job, operating on the patients. But as many of your listeners are possibly aware, the GYN oncology team operates and works out of University Hospital, not out of Meriter. And so there was, kind of a natural disconnect between the where the patients were located and where the providers were located. And so, part of our goal was creating a more formalized, organized, streamlined approach, which would allow us to speak to the patients earlier, allow them to meet their surgeons earlier, and allow us, especially with Aaron's help and with your help, to create a number of protocols that would function to provide more smooth transitions between the antepartum, intrapartum, intraoperative, and postpartum times. So I'm really proud of the work that we've accomplished thus far.
Great. Thanks for that description, especially about how the UW Health main hospital and the main birthing center of the UW system is the Meriter Hospital. Mike, briefly, can you tell us how many births are performed, how many babies are delivered at the Meriter Hospital per year, and how that relates to the other birthing centers in the state of Wisconsin?
Yeah, Meriter does about 5,000 deliveries per year, which makes it the single largest or busiest birthing hospital in the state of Wisconsin. So I think it really positions us well to both need this collaborative program, and to also really excel in the allocation of this care.
Let's talk about the multidisciplinary team that we're all a part of. And I'll have both of you speak on this. Aaron, specifically, what did you do to assemble this team and what drove this innovative program forward?
Well, I certainly can't take the credit for assembling the team. I mean, you and Mike were doing this back when I was just a first year fellow. But I really think one of the most amazing things about UW in general is how collaborative everyone is. And I have been amazed at how excited people are from so many different fields to want to be involved in this. We have a great group of placental pathologists. Dr. Gulliver, in particular, really has taken a particular interest in the pathology aspect of this. And so our pathology diagnoses, I think, are probably the best in the country, which we're really lucky to have. And she is like thrilled to be involved. We also have two radiologists who are exceptionally interested in furthering diagnosis of PAS. So certainly we use a lot of ultrasound, but ultrasound is not a perfect tool. And MRI has off and on throughout the years come in and out of vogue for being a helpful or maybe not helpful adjunct to ultrasound and diagnosis. But we have two radiologists who have done some amazing work utilizing a MRI contrast agent, which is pheromoxetol, which really allows them to be able to see the placenta better. And we have some really interesting work coming out of that demonstrating the helpfulness of MRI there. And then, we have a wonderful blood bank that is prolific and rapid and speedy, which we often need in the OR. And, we have a great group of colleagues who are always willing and able to come in and help out given the particularities of the case, whether it's a vascular injury at 2 o'clock in the morning or needing any sort of urology help from you and your colleagues at any time of day.
Yeah. Thanks for sharing all those different aspects. I mean, that's like a very large team of players. Mike, can you talk to us a little bit about the anesthetic considerations from our anesthesia colleagues?
Yeah, we've been lucky and happy to partner with the anesthesiologist at Meriter Hospital in order to provide very specific, tailored, individualized anesthetic care for these patients. Our primary concern is always keeping the pregnant patient safe. And so that's the kind of the foundation from which we start. And then, I think that our most common anesthetic approach nowadays is to receive a spinal or neuraxial anesthesia to start the case, which allows for, painless cystoscopy, painless insertion of the ureteral stents, and then delivery of the neonate in a way that the pregnant patient can still, meet the child and start bonding and that sort of thing. And then assuming that we proceed on to hysterectomy, conversion to general anesthesia with, intubation, and that allows for, kind of maximum relaxation of the abdominal musculature and optimized, visualization of the surgical field. And then in the case of, of operative hemorrhage, for safe transfusion of blood products, even if it needs to be done in a large volume way. And I think that this, kind of dual modality approach works well for our team and works well for the patients.
Yeah, that's a great overview on starting with a spinal anesthesia and then converting over to a general anesthesia. And I think that really sort of gives us a balance of control in the operative theater during a very complex endeavor. I was recently reading an article that mentioned a study looking at alternative methods of managing placenta accreta spectrum, specifically retaining the placenta. Aaron, can you tell us about this particular study that was done outside and your thoughts on it?
Yeah, that's a great question. There's been actually a few studies that have been done. France really pioneered this kind of approach a few years ago, and several centers in the United States have started to adopt it. I think it's a really interesting approach. So the idea is that it's a uterine sparing approach, meaning that essentially you deliver the neonate and then leave the placenta in situ and allow for the placenta to be resorbed essentially by the body. It has some really promising data associated with it in terms of being able to minimize the need for a hysterectomy, but really in kind of specific circumstances. So there remains a fairly high rate of postpartum hemorrhage afterwards, necessitating hysterectomies. And that's most common in the first, 24 hours to a few days afterwards, although can happen later as well. And so, one of the things that we struggle with a bit here in Wisconsin compared to some of the much more urban centers that have had a lot of success with this is that a lot of our patients are traveling from 2, 4, 6, 8 hours away and don't live close to a major medical center to be able to seek care should they have significant bleeding after they're discharged from their initial hospital stay. So it's something that we have not yet implemented here, although certainly have discussed and would be open to considering, should the right situation and patient come around. I think that this is a particularly interesting idea in cases where we see placental invasion outside the uterus, into the bladder, into bowel, into, vascular structures where the surgery itself could be life-threatening. And so allowing that as a possibility, I think, is a really interesting thought that Mike and I have talked a lot about and haven't done yet, but are certainly not opposed to trying.
Sure. You make a really interesting point about how our referral patterns impact how we take care of patients. Mike, can you speak to exactly how large our capture area is for placenta accreta spectrum?
We routinely receive referrals from all over the state of Wisconsin, and then increasingly with UW moving into the Rockford region with the inception of University of Wisconsin Northern Illinois Hospital, we're getting a large number of patients referred from Northern Illinois as well as Northern Iowa. So I'm very grateful for the team in the sense that we are able to provide this level of care now that we are clearly recognized as a regional expert.
Yeah, we have patients coming from the Upper Peninsula, Michigan, that are getting flown down, and Northern Illinois tends to be a traditional referral bed for the University of Wisconsin-Madison. Previously mentioned in our discussion was just the use of ultrasound and MRI. Anything else that's coming down the diagnostic space? I know, Aaron, you mentioned a specific contrast agent. Is there anything else that's ongoing in that field to maybe diagnose this or sort of evaluate how bad the placenta accreta is?
That's a great question. And there certainly is a lot of work coming out of some of the big centers, both in the UK and throughout the United States, looking at new ultrasound techniques to improve diagnosis. But as far as I'm aware, there aren't other imaging modalities that have been utilized. And I don't know of anyone else in the country who is currently using ferumoxytol in an MRI to diagnose either. And so I think we're, really lucky to have some very creative and outside of the box thinkers in radiology that are helping us with this. Because I think that, there's a lot of data suggesting that recognizing placenta accreta ahead of time and knowing about the diagnosis really improves outcomes. So, I think anything we can do to improve diagnosis only improves patient care.
I think that in years to come, we'll see some advents in still in the realm of ultrasound and MRI, but using AI and machine learning to try to get a better, even a higher, diagnostic accuracy for those imaging techniques.
This is a great sort of side discussion, which is the diagnosis of PAS. Sometimes we get into the case and it's not nearly as bad as it was anticipated on imaging, and sometimes it's worse. And having a sort of more accurate diagnostic tool would be a great addition to the armamentarium for your team. Let's talk about some of the Center of Excellence programs around the country that also manage this. Mike, do you want to talk about some of the bigger centers and how many of these cases they do per year?
At our research meetings through the Pan American Society for PAS or PAS Squared, they often delineate, what makes a high volume center. And that delineation tends to be, doing more than one or two cases per month. The well-known, well-published centers, I certainly, I don't have a comprehensive list of them, but I would say they include, big places in Texas like Baylor and UT Houston and UTMB, and then the University of Utah, Duke University, a few programs up in Boston. These are, when I think about kind of the hallmark big players in placenta accreta care, those are the ones that come to mind first.
And how many of these programs have a urologist that is actively involved? And how many of these programs use a GYN oncologist for the hysterectomy?
Lots of centers, will tout their, involvement with urology, but in my limited experience with the other places, I don't think the relationship is, quite as comprehensive as ours is, as it pertains to MFM urology partnership. And then, yeah, GYN oncology, I would say is involved at more centers than not. because they're, traditionally some of the most well-trained surgeons in OBGYN departments. And UW certainly is no exception to that rule. And so you'll see a lot of GYN oncology involvement in placenta accreta care, certainly elsewhere.
Yeah, that's a great overview of the nationwide landscape. And I think we're trying to do a research study actually that delineates exactly how much urology, vascular, obstetric anesthesia is involved. And I think we'll have to try and get that off the ground. Aaron, as a graduate of the MFM fellowship here at the University of Wisconsin, you have direct experience in the surgical nature of the program. My understanding as a urologist is that most MFM programs are not highly surgical. Can you tell us some unique things about this fellowship?
Yeah, that's a great point, Frank. And one of the reasons I actually came here for fellowship was how, much operating you can do as an MFM here. There certainly are programs, and I would say a lot of the big programs that Mike referenced do have a large MFM surgical component. So there are places that are similarly structured to have MFMs really, running surgical complications for obstetric patients. But it's not the norm, I would say. And I think that, the obstetric surgical training that I received during fellowship, I would argue is probably unparalleled. I certainly have not met any other fellows who had anywhere near the level of surgical training that I got during fellowship. So, I feel exceptionally lucky and grateful to have been able to get that. And, I think the program that you and Mike had started really facilitated that and, gaining that experience during fellowship.
Thanks for sharing your perspective on that MFM fellowship that you finished here, and now you're faculty here. I can tell you from my own perspective as part of the pelvic health center here at UW-Madison, and as one of the urology urogynecologists, that my fellows also are really interested in assisting during these cases when there's a difficult bladder dissection or a bladder injury or ureteral injury. So it's, I think, a really great adjunct to the standard core fellowship curriculum that people are getting. As we're getting close to the end of this program, I have one final question for the both of you. Mike, we'll start with you. Mike, if you had unlimited resources, what would you do to improve the management of placenta accreta spectrum?
If I had unlimited resources, I think that I would focus my attention on getting as many experts, as possible to the room. So at UW, every case would have both MFMs, and they would have an expert urologist like yourself. And I would focus as much of my attention as I could on doing a lot of intra-op imaging by coordinating with members from the Department of Radiology in order to give us the best sense of what is happening where inside the uterus, such that we can make the surgery as safe as possible for the patient. Yeah, I think that's what I would do.
Great answer, Mike. Aaron, a different question for you. These are extremely complex cases, and we receive a lot of those consultations that you manage primarily. What are some of the key challenges or barriers that you've encountered from those that are being referred from far away, and where do you think that's going to progress to in the next 5 to 10 years?
I think one of the big challenges and barriers is people either not being referred or being referred really late in their pregnancies. The earlier that we see people and counsel them, the more time they have to adjust to the diagnosis and the more time that we have to prepare. PAS is really challenging to diagnose. And I think that increasing awareness and increasing education to OBGYNs and to radiologists outside of the Madison area about what PAS looks like and what risk factors are and when patients should be referred would allow for patients to be referred in an earlier gestational age and, ideally minimize transfers from OR to OR when they're recognized intra-op at another facility, which is obviously not the ideal case. And so, one of my goals is to, start doing community outreach and education about, when to consider referral, what are things to look for on ultrasound to refer. And, so that's more from like a provider perspective. And then, I think for patient barriers, a lot of times it's the travel and the expense and the cost. And thankfully, we have a wonderful group of social workers who are really wonderful at minimizing the cost piece of it. And that helps a lot. And, I think Mike and I have been very creative about trying to schedule all necessary appointments at one time so that when we do have patients that are coming down from the UP, that we're able to get all of their appointments in at once so that it's just a single visit. And I think that has really increased patient satisfaction, but also increased patients' abilities to be able to receive care here. And then postpartum, we really work with local OBGYNs and family medicine providers and midwives to be able to have patients receive as much of either all or as much as possible of their postpartum care close to home so that they're not needing to travel to Madison for that.
That's great to hear that so many other, even social workers, are a part of this very complex management team. I'm very proud to be part of this multidisciplinary PAS center with both Aaron and Mike. I want to thank our two collaborators here, Dr. Aaron Bailey and Dr. Michael Beninati with Obstetrics and Gynecology as part of the maternal fetal medicine division. I'd like to thank Sandra Miller, our producer and editor, Dr. Kyle Richards for allowing me to guest host this particular episode, and to Dr. Stephen Nakata, our department chairman. I'm your guest host, Dr. Frank Lynn. Thank you very much.
Winnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.